When a group practice expands to IOP or PHP, the costly mistake is assuming the new level of care is just a busier version of the same practice. Treating a second level of care like more of the same is the assumption that turns a growth move into a regulatory and billing problem. Turning a group practice into an IOP or PHP, the operator decision points for licensing, staffing, location, payers, and workflows. We walk the operator's decision points: program scope licensing, staffing, location readiness, payer setup, and the workflows across both levels of care. Adding IOP or PHP can change your relationship with the state agency, public funding, payers, documentation, group programming, and payer review. In Oregon, the conversion can change your relationship with the Oregon Health Authority, public funding, and coordinated care organizations. It also changes clinical documentation, group programming, and payer review across the whole organization, not one new room. Run program-level services on ordinary private practice notes and claims, and you risk avoidable denials and under-documented care. The question is whether admissions, authorization, documentation, and revenue cycle support program-level services without avoidable denials or under-documented care. Clinician-level credentials do not automatically answer program-level questions once you add structured group programming and a marketed IOP or PHP track. Behave Health gives treatment teams one platform: EHR, CRM, RCM, treatment plans, authorizations, and reporting, designed to support program workflows, not just private practice notes. EHR, CRM, RCM, treatment plans, authorizations, and reporting in one platform, designed to support the program workflows a higher level of care requires. Your EHR, CRM, and RCM need to support program workflows, not ordinary private practice notes and claims. Before you market IOP or PHP, 4 operator decisions decide whether the expansion holds up: licensing, staffing, location, and payers. Each is a question to verify with the agency, payers, and counsel, not an assumption to launch on. Let us walk through all 4. Decision 1. Confirm which agency and service definition apply to the program, not just your clinician licenses. Adding structured group programming, SUD services, or a marketed IOP PHP track is a program-level question tied to the actual service model. Terms like outpatient treatment license may not match the state's categories. Verify which agency has authority and what definition applies with OHA and counsel. Decision 2. IOP and PHP operations require a different kind of leadership than an outpatient caseload. The program needs level of care assessment, group programming discipline, clinical supervision, documentation standards, and utilization review support. Define the population and service intensity first, then validate the staffing model against the agency, payer contracts, and any accreditation strategy. Decision 3. Your existing office can be an advantage, but it can also hide conversion risk. IOP and PHP place more pressure on group rooms, privacy, scheduling blocks, intake flow, family communication, crisis response, and documentation time. Treat the facility as a diagnostic. Can the space support the level of care, multiple sessions per week, and the existing practice operating alongside it? Decision 4. The payer question is bigger than whether a billing code exists. Separate 4 distinct issues. Separate agency certificate scope from Oregon Health Plan provider enrollment. They are related, but not the same readiness question. Then separate payer contracting and the documentation that supports the level of care actually delivered, verified with Medicaid and commercial payers before you rely on the revenue model. Operationally, 4 workflows decide whether the new level of care collects cleanly: admissions, authorization, clinical documentation, and revenue cycle. Admissions has to handle program-level intake flow, not the pace of a weekly therapy practice. Authorization and utilization review support become first-class workflows once you bill a structured level of care. Documentation must support the level of care actually delivered, or the revenue cycle exposes you to denials. The more established your group practice is, the more important it is to protect that business while you evaluate the higher level of care. Confirm the program model, provider enrollment, contracts, authorization workflow, and documentation before admissions begin. Protecting the established practice while you stand up the new level of care is the operator's job through the conversion. Behave Health gives the operating team a software foundation built for treatment workflows, so admissions, authorizations, documentation, and billing share one system across levels of care. EHR, CRM, and RCM in one platform, designed to support program-level admissions, authorizations, notes, billing, and reporting. Treatment plans, authorizations, and reporting are designed to support program workflows, not private practice notes and claims. Behave Consulting helps operators translate licensing, payer, and operational requirements into an implementation roadmap. Stop running program-level care on practice-level workflows. Book a 20-minute demo of the EHR, CRM, and RCM platform at behavehealth.com. See the EHR, CRM, RCM, treatment plans, and authorizations built for behavioral health programs at behavehealth.com.